Hi, good afternoon, everybody. This is Neeraja Reddy. I'm the VP for Genetic Counseling at MapmyGenome. Welcome to Genomic Gupshup, episode number 42. And I have the pleasure of having with me here Anu Acharya, CEO of MapmyGenome, and Dr. Jenny Prabhu. She is an MD in Pediatrics and Internal Medicine. Dr. Jenny, welcome to our Genomic Gupshup. And we're going to talk about longevity today. So very excited for this conversation with both of you, and have the pleasure of picking your brain on this interesting topic that has been going around, and there's a lot of research. So I have a bunch of questions lined up, but I want to begin with just asking both of you first about a little bit about your journey, this far today. So I'll let you start first.
Thanks, Neeraja. I think it's good to see Genomics Gupshup evolve. I think we started about a year ago, and now it's great to see that. And welcome, Dr. Jenny. So I think just as a little little bit about my journey. I think many people know that I graduated from IIT Kharagpur and was in the US, and around 23 years ago exactly, which is interesting because it's 23 chromosomes that we have. We started Optimum Biosolutions, which was a company also in genomics, and it was in the US and in India. And then we went on to doing 3 acquisitions in Germany, in the Netherlands, and the US, and we became one of the largest genomics services players worldwide. What was interesting at that time was the fact that genomics was used primarily in research, was used also by pharma companies and the FDA and others to be able to look at it in terms of how it can be used in the clinical space. But what was also emerging at that time was the fact that consumer genomics had also started to come about, right? So we had some companies in the US that had started to come about at that point of time. But when we looked at the whole space of personalized medicine and where it was headed, I think what was interesting was that we wanted to make sure that this could be something that we can use with data that comes from Indian population, which was a large majority of the population, but yet we couldn't find that data that was there, even in the databases that we were using at that point of time. So I think that was where we thought that doing something which would involve looking at data that comes from the Indian population was number one. The second thing was that when you look at most of where healthcare is, I think most of the spend was in once you became very sick, you go to the doctor, and then it's too late, and by the time I think the doctor is trying their best, and you can maybe increase their lifespan or the time on earth, but it doesn't really improve their quality of life. So I think one of the things that we were looking at was saying, can we look at prevention? And that's where about 10 years ago, we started MapmyGenome. And MapmyGenome was started with a simple concept saying, can we start with a product that will come to somebody's house instead of you going to a clinic or a hospital, be able to order it online, get that kit in the mail, and be able to do that. So we started with that. Today, of course, I think we've evolved. We've evolved towards a space where we are looking at longevity as one of the prime areas of where we can focus our energies in the preventive space. But we also have a very thriving clinical business where we're seeing a lot of doctors that would use these tests for their patients, not just in finding out which drug works for them, but also in terms of solving like a diagnostic odyssey and things like that. So today I think we are maybe what we call as a full stack genomics company, and that's where we are today.
That's wonderful. Thank you so much for that lovely background. And, I agree. I think we're a full stack genomics company now. Dr. Jenny, do you want to speak a little bit about your journey and your practice in the US and then your experience now here in India?
Sure, yeah. So thank you, first of all, Anu and Neeraja, for having me. I'm excited to join you today. So actually, genetics is one of the main reasons I decided to go into human medicine. I say that because if you had asked elementary age Jenny, I would have told you I was going to be a marine biologist and save the whales, but clearly that's not what's happened today. When I took a genetics class in college, I really did fall in love with human medicine, and that's partially what brought me here today. So I studied in the US, met and married my husband, who is originally from India, and went to medical school at University of Maryland. and decided to take a slightly different journey than a typical doctor. I specialized in both internal medicine and pediatrics. So it took me a little longer, but I'm really happy that I decided to go that route because it really helps me be able to treat more people. And then some point we decided to make the journey across oceans to land in India and start our own company here. Already, my husband and I were kind of working together, I in the clinical space and he in the research space with something called lifestyle medicine. So Anu kind of touched upon it already, but basically it is using non-pill-based treatments like dietary changes, fasting, meditation, and I'll probably touch a little more on this later to change your overall health and hopefully improve your lifespan. So we started a little bit in the US, but decided to continue it in India. And so that's what brought us here almost exactly, actually 3 years ago. We came to Mumbai. And really excited that there is more and more emphasis on genetic testing and not just for deciding what diseases a person may or may not develop later on in life, or in a child's case, what they were born with, but it really is guiding our treatment now, and we're able to recommend new and improved treatments and better treatments so people have a healthier and longer life. So genetic testing is exciting. I definitely think it's the wave of the future for clinical medicine. So it's exciting. It's good.
Yeah, thank you for sharing that. And I do agree it's exciting to hear the approach of, non-pill based treatment, because I think it's much needed, where we kind of move away a little bit from the medications that we tend to use. So there's been a lot of research on the blue zones around the world and about longevity. So Dr. Jenny, can you shed some light on, what were the most important things that we have learned from, these areas where we have seen a lot of centenarians, and we've seen that there's definitely people live a longer and a much healthier life. So what have we learned from research in these areas across the world?
Yeah, these are really fascinating groups of people. There's different kind of hotspots, Greece, Japan, Southern California, Italy, and I'm probably forgetting another one, but basically they all have kind of general things in common. The one that's most interesting to us as a company, because we talk about this so much, is a mostly plant-based diet. So this does not mean that they're vegan, although they eat less animal-based products, but they still do have a little bit of meat, a little bit of dairy here and there, a little bit of egg here and there, but 95% of their diet is plant-based. And more medical research is showing that a mostly plant-based diet, to make a long story short, reduces the level of inflammation in your body. So it allows you to live healthier with less disease. So that was the big thing that is across the blue zones, but also these people live in a cleaner, less polluted environment. They have less stress, which I think is actually a huge thing that we all need to keep in mind. They walk more, they stay active well into their 80s, 90s, 100s, whether it's gardening or cooking or whatever. So they just have kind of happier, and as you had mentioned, or as we had been talking about earlier, they have a better health span, not necessarily lifespan. So they're living life to the fullest. And I think we should all aspire to make our own blue zones at home.
Absolutely. So what we understand from this is that there are, many non-genetic factors that we are looking at that contributes to, overall health span, which is, the number of years somebody lives healthily. And also, can you talk a little bit about, the gut microbe? There's been a lot of research around the gut microbe and how does that influence our overall health, but also our longevity. So I know if you could speak a little bit about, what is the gut microbe? How do we test for it? And also, does this remain the same throughout our lifetime?
So thanks, Neeraja. I think, it's interesting, and maybe I'll just talk a little bit about, since you were talking about blue zones and all that, I think one of the things that we had started was the social thing, where we said, is it the role of influence of genetics or lifestyle or both? And I think what's interesting as we start seeing is a combination of the two, right? And since you asked about the gut microbiome, I think that was something that we recently launched about a few months ago. And we feel that increasingly we are seeing a lot of connection between the gut microbiome as well as disease risk and longevity. Right? So you want to understand, what kind of microbes you have in your gut. Now you can also, other than the gut microbiome, there are other microbiomes that you can look at, which could be your, the oral microbiome. You can look at other microbiomes as well. But the gut microbiome is a very good predictor of a lot of different things, right? You want to understand, what kind of bacteria, fungi, viruses, and others that are there currently residing with you. I mean, you're not just a human. I think you have a lot of microbes that live within you, right? And these microbes also are very nicely correlated to disease risk. They're also correlated to many other things. Basically what you're doing is you're taking a sample, and how you take a sample is basically you take, in the case of the gut microbiome, typically you would take a stool sample, and you take the sample, which comes in a little box, similar to what you would do with, other tests, but it comes to you, you take a little of the stool sample, and then you run what we call as the metagenomics, right? So you're basically looking at all the microbes that are there. You're looking at the signatures for each of these, and then you can basically say, you can quantify and say, you have this much of firmicutes, this much of proteobacteria, or different kinds of bacteria that you have, or different viruses and others. But it's not just about saying you have these bacteria and fungi, but you want to also correlate that to disease risk, right? So you can see that, are you seeing a little bit of, the propensity towards type 2 diabetes or obesity or even depression and other such things. So you do that, like a correlation between disease risk and these microbes. And then you are also looking at certain kinds of deficiencies in terms of your nutrition deficiencies, vitamins and a few other things. So all of that is given. Then we can also find out what you can do to actually counter that. Right? So for instance, if you have certain kinds of bacteria that are high, you want to be able to take in either a probiotic or other foods that can sort of supplement or can manage that. The other question that you asked, which was basically, does it remain the same? And I can tell you that I've done it at least 4 or 5 times by now, and I can very clearly tell that it doesn't remain the same, right? And it doesn't remain the same because unless, of course, you are that person who doesn't change anything in their diet, doesn't change anything in terms of their stress levels, and doesn't change anything in terms of sleep and other things, which is almost practically impossible, right? But, I could see that when I was on a normal diet, that my microbiome was very stable. It showed great. You look like you're doing all the right things. And then during Diwali, when I changed my habits, and I was saying, a little bit of cheat day became a few days of cheat days. I think you could start seeing that it said that you're eating a carbohydrate-rich diet. It showed that my microbiome was a little unstable and so on. So I think that's what you can see, that the gut microbiome can change and change as soon as you change any of these external parameters that are there today. And genetics also, of course, also plays a role, because that sort of predisposes you to certain of these things. So I think that is where we are. And I think more and more we are seeing correlation with your longevity and with disease risk and so on. So as we understand it more, I think we'll be able to also see many more newer types of therapies that can also be brought in to be able to manage these conditions of the gut microbiome.
So it's interesting that the microbiome actually tells you what you truly are, right? It tells you what you're truly doing to yourself, no matter what the client tells you or the patient tells the doctor. So that is an interesting way to calibrate and to validate what exactly you are doing to yourself. Well, thank you for giving us a detailed explanation on that. Dr. Jenny, so as a genetic counselor, we do see a lot of cases in pediatrics where we are seeing an increasing number of kids who are getting diagnosed with diabetes or pancreatitis or even ADHD, autism, or any other inflammatory conditions as well. So we've constantly seeing these numbers rise and more diagnoses happen. What are your recommendations in terms of improving lifestyle and diet that would also help some of these children reduce the risk? And what do you think are the contributing factors for these?
Yeah, so I mean, there's, of course, everyone is born with a genetic predisposition to certain disease states, but the good news is scientists and doctors have realized that there's something called epigenetics. So basically that means, yes, you have the framework's not going to change, but there are certain protein making parts of your genome that can be turned on and off, meaning certain diseases, if you're, let's say you may have a high risk of developing diabetes in the future, type 2 diabetes in the future, if you change your lifestyle, if you change your daily habits, amongst other things, then that genetic risk can be turned off later on, which is was a huge and still is a huge discovery. So it doesn't mean you are everything's set in stone, basically. So that's what, if there's kiddos that we see that come to us that are a little overweight, maybe a little obese, or they've started to develop signs of something that runs in their family, or something even that was found on a blood test or even a newborn screen, there's hope for them that things can be changed by making positive changes in their life. So I kind of like the blue zones, the most important thing we talk about is diet changes. So again, not trying to make everyone vegan, and more, something I should have mentioned earlier, more whole foods. So meaning less processed or not processed at all. So something that has additives or preservatives or has been broken down so the nutritional value is completely gone is just empty calories, and can actually also contribute to inflammation and just negative effects on the child. So having good whole fruits, vegetables, grains, legumes, nuts, seeds, etc., and making those mostly plants, in the long run, you'll almost guaranteed to see positive changes, less disease. And then also easier said than done, but trying to reduce stress, allowing more playtime, if possible, allowing vacation. You don't need to go somewhere fancy, but allow your child just to be a kid. Exercise doesn't have to be a specific sport, just going out and going to the garden and playing, taking a walk with the family. And sleep. I think we as doctors forget to tell people how, and we ourselves forget to focus on how important sleep is. So getting good quality sleep, making sure your child doesn't stare at a screen right before they go to bed or wake up and stare at a screen right away. Read them books, let them read books, let them kind of gently transition into nighttime and have an appropriate number of hours of sleep as well. All these things are mostly controllable, and you can kind of move towards these goals over time. We don't expect it to happen overnight. Those are things that can help significantly. We've seen it help significantly in our kiddos and in our adult patients too. So it's nice to be able to offer something, treatment that doesn't mean, giving injections or taking pills or liquids. So hopefully all of us as physicians will head in that direction in the future.
Well, thank you. Those are, I think, important tips to remember in terms of improving overall quality of life and also health span. And yes, it's a more holistic approach to, living healthily. So that definitely helps. You mentioned epigenetics. Anu, can you talk a little bit about what is epigenetics and how can we test for it? And is there a method that we can utilize to understand how our environment is influencing our genetics?
Yeah, so I think, Dr. Jenny explained what epigenetics is, that you're basically trying to understand the influence of environment on your genome, not necessarily in terms of what you inherited. So if you think about it in very simple terms, you are inheriting certain things that come from your parents, right? And that's what you would look at for instance, in a genome pathy and others. But we also see that, in the whole, when you look at the whole genome, for instance, there are certain parts that either when you look at it from a methylation point of view or anything else, you'll be able to actually study them, right? So just like, when you are looking at all of this, you can now look at certain markers that will show you whether these particular areas are turned on or turned off, right? And that's what we are doing in an epigenetics test, right? So they can do two things. One, you can understand what your biological age is today versus your chronological age. Your chronological age is what you're born. If you're born in 1972, you are probably like 51 years of age today. But it is possible that if you have done the right things to your body, that you are, maybe in your 40s, or if you have done the wrong things, you are in your 60s or 70s, right? So that is one thing that you can understand using an epigenetic study, because you're looking at all of this and it weighs, you're basically creating a biological clock, right? So that's number one. The second thing is you want to also understand specific areas on where certain things have, what has happened today based on your lifestyle. And you can also study that and do a detailed analysis of that. So the way we would do this is typically there is, there are either you create your own customized version of the chip, or and by a chip, I mean a microarray chip, or you're looking at a more off-the-shelf product like an Epic chip, right? So you're taking all of that and you're being able to run these tests, and you're going to be doing that similar to what you have normally done with like a genome patri, but you're looking at a different analysis altogether. And that's what we would be doing, right? So your technology is similar, but what you're studying in terms of the genome on that particular area is different. And so that's what we would be doing. And then the idea is really that how do you help people with personalized way of saying, can you change certain things? What are the vitamins that are currently needed and things like that? What are the nutrition needs that you have? And also, I think when people start measuring, they're able to see what has changed, right? So if you can start measuring and saying that, okay, maybe today it is showing 60, but 2 months later, I see that it has become 55, I think I'll be motivated to, get back to where my current age is or even younger, right? So if we can reverse our aging, I think then we would have solved the problem of, reaching 120 years or more, or getting to nirvana. Of course, we are not yet anywhere close to that. But at least I think once we start understanding, how we are doing, in terms of your changes in lifestyle and what effect it has, I think that measurement, that quantification of it becomes a lot more motivating for people. And like you mentioned, like the gut microbiome doesn't lie. I think your epigenome will help you to be able to see what you've done actually in writing, right? So I think those are the things that we have started to see.
That's interesting. Very, very fascinating to hear this. And I think, yes, it's a great way to measure, where we stand and what we are, what's lying ahead of us. So in terms of when you look at the overall health span versus lifespan conversation and think of a population, we do know that there is a huge burden of genetic disorders, especially in the pediatric settings in India, right? So how do we tackle that? What kind of tests are usually offered in a pediatric setting? So I think I'll let both of you take up that question.
So I can speak to, I could start, I guess, and then Anu, you can continue. So there's different stages in pediatrics that you can offer testing to parents and to the children. So there's preconception testing. So the father and the mother, potential father and mother are tested, their own genomes are tested, their own genetic risk for disease is tested, and then kind of calculated what the risk for their offspring, their future children would be of certain genetic diseases. So that can help guide, I guess, expectations and things to look out for future pregnancies. And also, if sometimes it's after the fact, if there's been one child born with a genetic illness, then the testing can be done for future siblings of this child. Then there's prenatal testing, which is when the mom is already pregnant. And so there's non-invasive testing, which is the NIPT, which is a blood test, and that looks at the mother's cells and the baby's cells that are in her bloodstream and determines, again, the risk of the baby's actual risk of certain chromosomal abnormalities like Down syndrome, things like that. And then that can further be confirmed by more invasive testing like amniocentesis, which looks at the amniotic fluid, and that gives a more conclusive, although still never 100%, because I think we had mentioned the other day, a lot of times what's seen on the test results, you really have to see the features of the child or the physical, like how certain systems in their body work, and that isn't really known for sure until they're actually born. And then finally, there's, not finally, but as in early life, there's neonatal screening. So in a lot of countries, and India more and more now, which is good, they have the newborn screen. So just a small amount of blood is taken from the baby from a heel stick. And from that couple tiny drops of blood, we can tell so much information about metabolic diseases, again, genetic diseases, and things that basically, if we know about it early, we can start the treatment right away. And there are many examples, but thyroid hypothyroidism is a great example. If you start the baby on treatment immediately, then he or she will live a completely normal life. And then there's certain enzyme deficiencies. If you replace the enzyme, or if you leave the certain, you have a certain diet, then again, the baby will live a totally normal life. So it's amazing that medicine has come this far, because, you know, I guess like 40, 50, unfortunately, a lot of these children would not have normal lives. So it's great that we have that ability now. And I'm happy to see it happening more and more in India, and of course, other parts of the world. I think, and we'll probably, I'm sure you'll ask us this later, but the access to this can be an issue. But I know Anu and her team are working on making that better for people. So that's good.
Absolutely.
Maybe
Anu, what has been your, sorry, go ahead.
No, go ahead. You asked the question. I thought I'll just add to that. Yeah.
No, I was curious to understand what was your experience in, the last 20 years of being in genomics. Have you seen the uptake, or is there more interest in the genomics application, especially in clinical medicine?
Oh, absolutely. I think we have started seeing, and I wouldn't say in the last 20 years, in the last 3-4 years, we've started seeing a huge spurt, right? Like, I think there's been a lot more acceptance. I think people have started seeing the value of these tests, and therefore, both in clinical practice, but also in preventive space, we are seeing that. Now, one of the things, and I think Dr. Jenny explained all the tests really well, but maybe I thought I'll add a couple of points, which, in India, we do a lot. There are a lot of arranged marriages, right? So you look at a lot of different things. You're looking at, compatibility and all of that. But there's one thing that I think I wish more people would look at, which would be the preconception testing, because you don't want you don't know the person, so you'd rather at least get that part right? Because that's ultimately the health of your family. There are also a lot of consanguineous marriages in India, and I feel that if we are able to actually let people know why there shouldn't be those with real examples, I think we'll see less of that happening. So I think, in the case of arranged marriage, you look at your Janam Patri, but you should probably also look at your Genome Patri and
Absolutely.
things as well, right? So that would be one point I wanted to add. The second thing that I was also saying is, seeing is that, while there are lots of these tests, I think there are not that many people like Dr. Jenny. Like, there are now an increasing number of doctors who understand genetics, but I think, that area where if we can get more educational content out there, because everybody is a busy doctor, if we can get them to understand more of genetics, I think it will help everybody, because everybody wants best solutions for their patients. But in terms of just the overall testing and what we have seen, I think OBGYNs and pediatricians and oncologists are the ones that use these the most across the country. And we are also seeing a lot of conditions like epilepsy and others that are more in the neuro space, that we are also starting to see a lot more, people, doctors, and wanting to understand the solution, because sometimes the symptoms might be very similar, but you want to be able to understand, what is causing that, right? So understanding that brings a lot of closure to families. And I think nobody understands that more, let's say, like you do, Neeraja, because you are counseling a lot of these these
Mm-hmm.
parents and families. And I think that brings another point that,
Yeah.
there is probably a connection that can be created because of the genetic counseling family that has been created across the country.
Yes.
And I think the number of counselors that we have today can actually be that nice bridge between the medical
Mm-hmm.
professionals as well as what you need in the genetic testing space.
That's very true. That's one of the major roles that we see as genetic counselors is to advocate for the patient and also bridge that gap between the clinicians and the patients. And of course, we need a lot more genetic counselors to the number of, people that we are serving right now. Um, and I do agree. I think we have definitely seen a shift in thought process where we are seeing more families taking up preconception genetic testing, carrier screening prior to getting married. And it's a very nice change in thought process and practice that we are seeing. I myself have seen a couple of people who, have come in and said we want to consider marriage only if everything goes well with the genetic testing and we don't have a risk of, an autosomal recessive condition. So that's definitely a good shift. And I think it also goes back to the awareness that you were saying that we need to educate more, put out more educational content out there for it. So let's talk about pharmacogenomics here in a bit, because I think, again, longevity relates to, a lot of drugs that we are taking and how do we circumvent some of these diseases that we have, of course, goes back to, healthier life. So how do you describe, the application of pharmacogenomics right now in the clinical setting and what are we able to offer?
So I think pharmacogenomics, basically, which is looking at a person's response to certain medications and if the medications will work for them or if they need a certain dose, a higher dose, a lower dose based on how they metabolize or how they, the medicine is, what's the right word I'm looking for?
Toxic.
Process. Thank you. That's the word I was looking for in their body. So some people process it quickly, so they need a higher dose. Some people don't process it fast enough, so they need a lower dose. And some just, it's not compatible with them at all, so they shouldn't even take that medicine. So this is huge in clinical medicine, in both in the inpatient setting and intensive care unit, both adults and kids, but also in outpatient medicine, because unfortunately we spend a lot of time giving different medicines to kind of trial and error to patients. If we had, and it's there now, but if more and more, if we have as part of the patient's medical record, these are the medicines that I can take. If I take this medicine, I need this dose versus this dose. It's more likely to interact with this medicine. It'll save so much time and money and side effects. I think it's huge. It's, again, I keep saying the future of medicine, but it's really exciting because we end up chasing side effects from medicines with new medicines, and patients stay in the hospital longer because they've developed a kidney issue or a lung issue from certain medicines. And then one other thing that I'm very passionate about is antibiotic resistance. My father was a big researcher in antibiotic resistance in the United States. And so that's something very close to our heart as in our practice. So this way, if we know if a patient can take a certain antibiotic, if they'll react well to it, then we can put them at the lowest, safest dose for the shortest period of time. And that will influence not just that patient, but millions of other people. So it's a exciting time in medicine. And I think if that becomes just like you have your child's vaccination record, or just like you have your history, your surgical history, your x-rays, et cetera, you should also have your pharmacogenomics report that you carry around with you.
Absolutely. I think there's a huge benefit in doing that. Anu, can you talk a little bit about how many drugs can we look at right now? And I think what Dr. Jennifer said, like antibiotic resistance, like these are important, drugs that we take even in a general setting. And unfortunately, in India, a lot of this is available over the counter. So how can somebody learn about, the drugs that may be well suited for them or may not be well suited? And how many of those can we look at right now?
So currently in Medicamap, which is one of the products that we have, we are looking at 165 drugs, right? And these are drugs that have been either approved for pharmacogenomic testing by the US FDA, or and these we are looking at guidelines that come from the CPIC guidelines, the Swiss Medic, the HMDC, and so on. So there are many different guidelines that different countries and others have created, and based on certain evidence that has been created. So that is what we are doing. And the idea really is that if we can create like a easy to read report where doctors can see that if it is green, then whatever is the normal recommended dosage can be given, I think it is fine. Right? But if it is either yellow or orange or red, then you want to also see what needs to change, right? Whether it is about changing the dosage, like Dr. Jenny said, if you're an ultra metabolizer versus somebody who doesn't metabolize it that fast, there are certain recommendations in terms of how you would take that drug. The other could be that this drug might be toxic for you, and therefore you don't want to take that drug and change it to an alternate drug. So we are seeing that some doctors prefer to do only one specific drug that they are looking at because in majority of the cases, drugs don't work on a certain population. And so we are seeing that some doctors want to only look at that. But when they find out that you can get a whole profile of your drugs in one, just doing that same test at not very different pricing than what you would do for one, I think they're happier to be able to get that, because that becomes because typically I think if somebody is on cardiac drugs, the chances that they will be also on diabetes drugs and others also increase. Right? Similarly, I think when you're looking at other things, you also want to understand not just for that particular drug, but you also want to understand if there's a drug-drug interaction or if there's a drug-food interaction and so on. So I think this becomes a baseline for a lot of different kinds of way that a doctor can actually help their patient. And I think that's why it's becoming a very popular. If we can save, more lives by not having as many reactions, or if we are able to help them get their treatment faster, I think then we would have done a good job and be able to, help the medical professionals a little bit more.
Absolutely. So there is definitely more and more, I think, uptake of pharmacogenomics, like you said, especially for the critical patients, starting from there to, a lot of people who are saying, I'm not taking any drugs now, but I just want to be prepared in case I need to do that. So in terms of, genomics, as we think of all of these tests that are available, and I think technology has done great in the last decade, in terms of genomic technologies, we've improved a lot and we're able to offer a lot. But what about accessibility? I think especially in a country like India, we still have a lot of population that is rural and is not accessing any of these services that we can offer. So what do you think are some of the challenges and how do you find solutions for this? I think I'll take both of your perspectives. I'll start with Anu first.
Yeah. So I think that, we thought of accessibility and affordability and all of that right in the beginning. So we created a product that is accessible. But unfortunately, I think we realized that it's not just about creating a product. We also have to educate people about using it. Right? So you have to have the medical community recommend that to their patients, right? So we have, preventive set of products, and then we have the, products that the clinical usage of that, right? Like, let's say when you're looking at it from, understanding why there's a recurrent abortion, or you're trying to understand it from an oncology patient and so on. Now we've made it such that people can order a test, and anywhere that a courier can get to you or a post office can get to you, you can get access to the test. So we call that the Har Ghar DNA, right? But I think where we lack today is more, how do we get this message across, right? So maybe one of the places where I don't think we have spent quite enough time is how do we make this in languages that they can understand more than just English and Hindi and things like that, right? So that I think is an important piece that I feel we have not done justice to. The second thing is, can we create this information that we can pass on to the medical community in simpler terms, right? So we are trying from our side, but I think we need to work together with the medical community to be able to create something that creates more value for them, and therefore they can actually be able to pass it on to the patients. And the third thing I think is access and affordability are very closely interlinked. Right. So we've always had, so 10 years ago, we created a product that you can order online and get it to your home. But when the price dropped, we saw a jump in the number of people who are looking at it. Right. So I think there are many aspects to accessibility. And I think, it would also be helpful if, for instance, for people who can't afford it, if we can find the right kind of payers, right? Whether it's the government, whether it's insurance or others. And I think that's one area that we are lacking quite a bit today, because we don't yet have a way of somebody paying for these tests. And I think we saw that a large part of what happened in the West was primarily driven by these payers. So today, I think on LinkedIn, I was just responding to somebody and I said, why is it that we don't have good quality health insurance? I said, it's a chicken and egg situation, right? Like we have a very small base to start off with. People don't want to spend money because they can't spend that kind of money on a cover because they don't see the value of it. And because of that, you don't have enough coverage. And when you do have somebody who claims insurance, there's too much cost that is attached to that insurance, right? So I think I was telling them that if you focus more on preventive strategies, it becomes a lot more valuable for individuals and for the insurance companies. So I don't know what Dr. Jenny has to, say about that, but those were some of my thoughts on it.
Yeah, I mean, I totally agree with you with the prevention aspect. So yes, in this case, the upfront cost may be a little more for an individual or for an insurance company, but if you look at the bigger picture, if you can prevent diseases that can cause a lot of disease burden, meaning hospitalization, lots of medications, long-term treatments, and early mortality, like earlier death, then if you can prevent that with a one-time, at the time, relatively high cost, but down the line, it's minimal compared to the amount of money you'd have to spend, the family would have to spend, or the hospital would have to spend, for example. So that's really important, I guess, to make the insurance companies and maybe someday the government aware of how cost effective this is. If you look, another example is in the West, I study in the US, so I can speak to the US. It's mandated that every newborn gets this newborn screen, and it's covered by government insurance or by private insurance, whichever way. But every child gets that, and same in Europe, I believe, also, at least the UK, I know. So, that saves so many lives and saves so much money, again, in terms of disease burden and, of course, psychological burden for the families, et cetera. So that would be a great goal to move towards. I know that's a big undertaking in a country that has such a huge population, and there's big cities and small cities and rural, so that that's not an easy task, but that's a great goal. So hopefully at some point it'll get to that. I think it's just awareness again of the government, but also awareness of doctors. We need to be better about offering these tests to our patients, and being aware of the implications of offering the test and how much it can help people, not just clinically, but in their lifestyle. And then patients need to be aware they need to have the education to ask for it. If their doctor's not aware, then they should say, hey, what about, I heard about this pharmacogenomics test, or I heard about, this test before I get married to this person. I just want to know, maybe we can find out how our genetic compatibility is. So I think it's awareness on several levels that will help genetic testing be more available throughout the country.
Yeah, absolutely. Thank you. I think that's really well put together. I think those are very important points that we all work towards. And with respect to the newborn screening, I know there's more discussions about implementing that as a part of the routine healthcare in all hospitals, and we're all hoping that we get there soon. So now that the human genome is fully sequenced, where do you think the future lies with human genetics? And again, I'll let you both answer that from both clinical as well as the industrial perspective.
You want to go first, Dr. Jenny, or I'm happy to take it?
Yeah, you can go first. Go
okay. So I think that what we are starting to see, both from a technology perspective, and of course, the human genome is now fully sequenced. We have a good reference, but there is still, I think, more data that needs to be got for some parts of the populations that I feel is important, which will continue, right? So that baseline in terms of how do you create better reference population, I think is very important. So that's definitely still something that while it is fully sequenced, we still don't have it for all populations in a way that is, clinically actionable for everybody, right? So that's number one. The second thing is that we have started seeing more of a lot of these understanding of, let's say, methylation and the epigenetics and all of that. We're starting to see that. But we'll start seeing it in a way that will become more accessible and affordable for the average consumer. Because we are today seeing that this is something that's still a very niche segment. There are very few people who understand, because I think from a science perspective, we've only recently understood that. So we'll start seeing more of that. I think the gut microbiome, if you start seeing the therapies that attach itself to it, whether it's fecal implants and other therapies that are there, I think you'll see a lot more of it integrated into clinical practice. On the screening side and all, I think clearly, I think the Indian government has also come up with some Nidan Kendras and others for newborn screening and others. And I think once we show there is real value, I think we'll start seeing that, genetics is going to become a more, it's going to be knit into the whole medical fabric. So you'll be able to see that if you have that history and all that. But I feel that the real value will be if this becomes part of your EMR. At birth, you sequence a baby as soon as they're born. And I know that, Harvard has done a few studies and a few other places they've done that. But if you can do it from the time somebody is born, or even prior to that for the parents, then I think you are able to, create a decision-making system for medical professionals, for the individuals. And I think with AI, you are able to put these pieces together, right? So one of the things, for instance, what we are doing is connecting the dots between your genetic profile, your blood markers, and your other parameters. I think we can create those kind of decision-making systems and make it more real time, right? So I think that's where we see that this will become a lot more real time. So your baseline, which is there, which is created at birth, can then be used to be able to say what happens later, right? So if you've gotten something, then you just look at changing baselines, but use AI to be able to then help you predict what next to be done. So I think that's where I think we are headed. Maybe Dr. Jenny can give us a more realistic view of where we are.
Yeah, I mean, it's exciting that the human genome is now known, and even more exciting to me is the epigenetics aspect, that you can modify how your life will end up, and how long your life will be, and how good your life will be, how healthy it will be, now that we have more information in our pockets. In our practice, we're very focused on preventative medicine. So, I think for up until very recently, most doc medicine. So you come with a symptom, you come with a disease, and we treat it. But we focus on preventing that disease from even happening, preventing that pain, preventing you from following the footsteps of your family members that had to suffer with diseases, for the second half or even the beginning of their life. So now that we have those tools, we can focus more on preventative care, which is our passion, just making people healthier, have a better health span. The other thing that's exciting about knowing more about human genetics in general is that all these, again, both adults and kids that have these unknown diseases, now we can get it down to the specific genetic foci, to that small area, maybe that one particular gene that's been affected. If it is a one gene mutation, then it can actually be treated. And, these really hopeless cases can actually be cured. And not just genetic diseases, but certain cancers. And now we're seeing certain viruses, things like that. So that's also really exciting. It's like a new wave of medicine. So lots of hope, I guess, out of genetics. With more knowledge, we can provide a lot more hope to our patients.
It's very futuristic, I would say, but also very exciting as genetic counselors, for us to, like what Anu said, we are often, meeting these families in length and, really connect with them for sometimes over a span of few years also, because we are following up with a lot of these clients. And so it's exciting to see more and more options. I know that, SMA now, there's a drug that is in place, and for DMD there are trials going on. So it's nice to see, and even in the preventative space, we can do so much more than just telling people that, oh, there's a predisposition now, right? So the gut microbe or the epigenetics, these things add so much value in that predisposition, and then figuring out how to keep things, going from there. So it's very exciting to see all of the progress, but it also brings the biggest concern for us as genetic counselors is the ethical use, like what Anu mentioned. Ideally in a futuristic scenario, you would want everybody to be sequenced and understand what the risks are and what we can do about it. But it also comes with a lot of data that needs to be protected and put in place, and have checks, to make sure that it's ethically done. So what is, your take in terms of what are the steps that should be mandatory in as we are progressing more towards getting genetics more and more integrated into the medical system?
So maybe I can take a shot at it in this. I think there is clearly, I think there are two aspects, right? One is that we would never have been where we are today if there wasn't data that supported any of the research that was done, right? So if there weren't enough studies that would say that this particular mutation is either causing a particular disease or is correlated with a particular disease, I think we wouldn't be where we are today. We wouldn't be able to offer any of the tests, right? So you can sequence all you want, but if you don't have data that supports it, you can't, right? So that's number one, that you do need studies, you do need data, but you don't need data that is necessarily connected to individuals, right? So you need these studies, and I think that's where people need to understand that there is a difference between data that is used in a large anonymized study versus data that is used to identify you and therefore be able to punish you or not give you certain things that you ought to be given, right? For instance, if somebody uses this data to not give you a job, or they use this data to not give you insurance, then I think it's a problem, right? But if they are using, if consented data, which consumers or patients say that I'm okay to use anonymized data for research is used, I don't think most people have a problem with that, right? So if people are okay with saying, I'm giving this data, use it in an ethical manner to be able to understand, the cause of disease or whether a drug will work for a particular population who has this mutation or not. I think that's a different thing than saying, I did not give you my consent or I don't understand what consent is. And therefore, and then my data is being given out to an insurance company or somebody else to deny me insurance or deny me a job, then that's a problem. So I think, we need to separate these out. And from an ethical perspective, I think consent is important. What kind of consent you take from a minor versus a person who's an adult, to help them understand what a genetic test is, and to make sure that they understand that this data, if used, where would it be used and how you would use that, right? So those are the kind of things that if you do correctly, I think we'll be able to progress, both in terms of how we do more research studies, but also in terms of how we would actually get, high quality of data without compromising what an individual might face if that data was connected to employment, insurance, or anything else.
Absolutely.
Yeah, I
Dr.
agree.
Jenny, did you?
Sorry, go ahead. No, I was just going to say, I totally agree with what Anu said. I think you have to walk a fine line between releasing all of, pages and pages of genetic data and individuals, because until everyone is informed about what it actually means, which of course is impossible, it can't be interpreted correctly. So this, again, I keep going back to epigenetics and environmental influences, but if I don't know, an insurance company sees that this person is more predisposed to a certain type of cancer or diabetes or thyroid condition or I don't know, male pattern baldness or something. I mean, it doesn't mean that is 100% what's going to happen. So it should absolutely not be used against them for insuring or hiring or even marriage, honestly. Like we talked about genetic testing before marriage, and but everyone has to understand that just because, the woman has this and the man has this doesn't mean that it's absolutely going to happen. Nothing is set in stone, and things can be changed by your environment and by your everyday practices for the better. So that's, the awareness is really important. Otherwise, it could be a huge ethical dilemma, and people start saying, that one, possibility of that one genetic disease occurring later on when you turn 90, therefore you can't live in this apartment building, or you can't have this job, or you can't run for office. So that, I think that's the biggest issue we'll be facing with that. And obviously consent comes before all of that. So I totally agree.
So I think maybe, one thing that maybe is, we might want to differentiate between the two. We mentioned the premarital testing. I think, people need to understand the difference between testing it so that as a family, that recessive condition doesn't become a reality, versus something that, let's say I have a risk for diabetes, which is a complex disease. There's an interplay of environment and your genetics. I think people need to understand that the reason why we would test for a thalassemia for both the partners is because the partners will have to live with a child that might have that condition. And if they're okay with that, I think then it is fine. If they're not okay with it, I think they need to understand, right? So I think there is slight difference between people who have a single gene, like a single mutation that potentially can be a problem for them, versus something that may be a possibility, if they do all the wrong things and so on. So I think that's something that maybe we can, hopefully we can educate people about. I don't know what, Neeraja, what do you think about that?
Well, that's the main reason why I completely agree, but that's the main reason why we, emphasize on the pre-test genetic counseling, is because we facilitate that decision making with the clients, and we make sure that they have the right information before they have made the decisions. I've definitely seen people who have looked at, the carrier screening because they want to understand risks that can be inherited and can get passed on, versus, couples who come in later and say, oh, we just want to understand. I've also seen patients who, come in and said, we want to have a child, but we want to understand what is our own risk of predisposing, diseases like diabetes or cholesterol, or what does our future look like? Like, we are healthy right now, but are we predisposed to any disorders before we plan a family? And I think that's also putting things in place, is that you want to be healthy to raise a family that is healthy, right? So that's the reason why we emphasize on the pre-test genetic counseling, so they have all this information before they make a decision, and more importantly, they understand the implications and the possible options they have after the reports come in based on what we find. And that really helps them make the right decisions for themselves based on their situations and perspectives. And I think another good point Dr. Jenny brought up is the cultural and the social stigma that can get associated with some of these. We've definitely heard conversations about, I have a skin disease and this is something that can be used against me or is currently being used against me. Even people with a family history say that they face a challenge with these things. So it's very important to educate, because they don't always understand that just because you have a father who has vitiligo, that you will end up developing vitiligo. No. So I think educating that helps in alleviating some of the stigma that gets associated with it, and the concerns of, what the society would think, or what we should be doing going forward. So yes, I think education is the key here to, make a lot of these things easier. And I think consent has to happen in vernacular languages as well, which I think something you mentioned is understanding consent is very important. So that is something that we need to work towards as clinicians, as labs, is also to make sure that consents can happen in a language that people understand, and something that is easy for people to understand. Yeah. Well, thank you, both of you. I think it was a wonderful conversation and a lot of good insights that I think both of you have shared. So since it's a custom that we always do rapid fire in Genomic Gupshup, I'm going to ask a rapid fire question to both of you. What is your most favorite longevity book? Anu, you can go first.
Well, it used to be Sinclair and David Sinclair's, and now it has become Epigenetic.
All right. Dr. Jenny, what is your favorite longevity book?
It's called How Not to Die.
Oh, I have that book.
Yeah, it's a great book, and I like it because it divides it up by like body system and different, and
Mhm.
how you can, if you are specifically prone, you know, in your family to liver disease or lung disease, you can kind of target those. You don't have to read the entire book, but I do recommend
Interesting.
reading the entire book. It's a good book.
Well, thank you. Thank you both for your time today. This was a wonderful conversation, and I look forward to more of these, insightful conversations with both of you. Thank you so much.
Thank
Thank
you.
you so
Thanks,
much.
Neeraja. Thank you.
Thanks.